Treatment of various kinds of stricture. The treatment of stricture at the meatus and of spasmodic stricture has been dealt with. Apart from these, the treatment of stricture may be considered under the following captions. 1. Stricture of large caliber. 2. Stricture of small caliber. 3. Stricture admitting only a filiform. 4. Stricture complicated by retention. 5. Impassable stricture. 6. Traumatic and resilient stricture. 7. Stricture complicated by prostatitis, irritable stricture. 8. Stricture complicated by false passage. 9. Stricture complicated by periurethritis or prostatic abscess. 10. Stricture complicated by fistula. 11. Stricture complicated by acute pyelonephritis. 1. Treatment of uncomplicated stricture of large caliber. After the diagnosis has been made by the passage of a bulbous bougie, no further instrumentation is advisable, if the patient can spare the time, until the effective exploration has been observed. The chances of urethral chill after the first examinations must be remembered. The patient's general condition and habits must be studied, and his urine tested for acidity or possible kidney disease. He must be instructed in urethral hygiene, the nature of his malady must be explained, and to forestall future disappointment, he should be informed at the outset that, after his symptoms have been relieved by treatment, the permanence of his cure, if his stricture is deep in the urethra, may depend upon his use of an instrument upon himself at proper intervals in order to prevent recontraction. Being instructed not to mind the smarting at his next urination, a few drops of silver nitrate are instilled, and the patient is instructed to take a tablet of hexamethylenamine after each meal and to return in 2 days for dilatation. Sounds. The treatment best adapted to the majority of these cases is dilatation with a conical double taper steel sound. One of these instruments, properly warmed and sterilized, is introduced in the manner already detailed. Its size should correspond to that of the bougie that has passed the stricture, and the utmost delicacy, care, and gentleness should be used in its introduction. As soon as the instrument has entered the bladder, it should be gently withdrawn at once. Nothing is gained by leaving it even for a moment. During withdrawal, the stricture is usually felt to grasp the sound. After one sound has been withdrawn, a second and even a third may be introduced if considered safe. It may be stated as a rule, subject to judicious exception, that if a conical still instrument of any size larger than number 15 French, when held in proper position, will not enter a stricture almost by its own weight after a little delay, it should not be used. Every urethra, however, has its own temper. Some are aroused by the slightest disturbance, while others bear considerable violence without protest. A surgeon should acquaint himself by gradual experiment with the temper of a given urethra before he takes liberties with it. The mischief to be feared from the employment of large sounds with force, besides false passage, which is not likely to be produced by large instruments, is threefold. 1. Epididymitis, a common result of violence to the urethra, and a complication which suspends treatment and confines the patient to bed for several days or weeks. 2. Inflammation in the stricture, which aggravates its condition and defeats the end of the treatment. 3. Chill and urethral fever. The third danger, the chill and fever, is very unusual after manipulation of the pendulous urethra. Witness the impunity with which many surgeons cut far and wide through that part of the long-suffering canal, and increases as we approach the bulbo-membranous junction. Some persons have a predisposition in this regard, and the presence of some renal lesion is essential as a predisposing cause of any real septic chill. Yet in no given case can the prognosis be definite, and the only safety lies in hedging the operation about with all possible precautions. The rule, which I have found most efficacious, is hexamethylenamine before, gentleness during, nitrate of silver or permanganate of potassium after sounding. At each subsequent visit of the patient, the surgeon commences with a sound from 1 to 2 sizes smaller than the last instrument introduced at the previous visit, and carries the dilatation as far as possible without the employment of force till the full size is reached. The interval. The most important feature in the treatment of stricture by dilatation is a proper regulation of the intervals to be allowed between the visits. The intervals usually recommended are too short. We can only repeat that it is bad surgery in treating stricture by dilatation to reintroduce instruments, unless filiform, before the lapse of at least 72 hours, and even longer intervals will often produce better results. The full size. As to the degree of dilatation which is to be aimed at, every urethra has its own gauge in the size of its meatus, provided that meatus be not congenitally small or contracted by disease. If there is any cicatricial tissue in the circle of the meatus, or if a probe can make out any pouching below the lower commissure, figure 46, the meatus is too small. In the majority of cases, this physiological gauge, the normal meatus, is adequate. A stricture once dilated to this size, which will vary from 27 to 32 French, will stand the test of a cure. That is, the inflammation about it, not necessarily the prostatitis, will rapidly disappear, and the stricture will not recontract during the lengthened intervals of sounding that constitute the after treatment. But occasionally the meatus is too small a gauge. The outer fibers of the scar lie so deep and are so elastic that they are unaffected by the pressure and tend to recontract as soon as the lengthened intervals of sounding permit them to do so. Such strictures must be cut or stretched with the Coleman dilator until a point is reached where they do not recontract. Footnote: Otis's theory. Such was the basis of Otis's famous theory. Meeting many strictures incurable by the half-hearted methods of dilatation then in vogue, and finding that a generous incision cured stricture of the anterior urethra, he evolved the theory that the urethra is an evenly calibrated tube whose size bears a direct relation to that of the flaccid penis. This ratio he fixed at 10 millimeters of urethral circumference to every inch of penile circumference. Thus, a 3-inch penis should take a 30 French, a 3.5-inch penis a 34 French. The objection to Otis's theory is that it is incorrect. The urethra is no more an evenly calibrated tube than the ureter, the esophagus, or the bowel. Its size no more varies with that of the penis than does the size of the esophagus with that of the neck. The objection to Otis's practice is that it involves an unnecessary and harmful amount of cutting, since, as a rule, the patient can get well without it, and the operation may leave a canal defective in expulsive power. Moreover, though this wide cutting cures strictures of the pendulous urethra, it does not cure deep strictures. Dilators. There is no question but that sounds of a size readily admitted by the meatus may be passed with less discomfort to the patient than any dilator. But if the stricture, when dilated to the size of the meatus, recontracts with undue rapidity, further dilatation may be performed by the Coleman dilator. This instrument is employed in the same manner as in the treatment of chronic urethritis. Urethrotomy. If at any stage of dilatation the stricture rebels and cannot be dilated any further, urethrotomy must be resorted to. Choice of urethrotomy. External section is best suited to strictures of the bulb, internal section to strictures of the pendulous urethra. There still remains a choice of instruments for internal urethrotomy, which choice is simply a matter of taste. For my part, I like the bisturi for strictures near the meatus, Otis's dilating urethratome for any stricture of the pendulous urethra large enough to admit that instrument, and Maisonneuve's urethratome only for those strictures through which an Otis instrument will not pass. After treatment. The after treatment depends upon the location of the stricture. If the stricture is in the pendulous urethra, the surgeon may feel confident that a cure persisting 3 months will prove permanent. When the stricture has been dilated fully, so that there are no longer any large shreds in the urine, unless from the posterior urethra, the patient may be dismissed to report in 2 weeks. If at that time there is no recontraction, he may be dismissed for a month, and again for 2 months, when his cure may be pronounced permanent. If, however, there is a relapse on any of these occasions, visits must be renewed, and the patient's cure ensured by higher dilatation or a further cutting. If the stricture is in the bulb, the matter is different. In all such strictures, except those soft bands that yield to 1 or 2 passages of a sound, recontraction will almost inevitably take place, unless the cure be maintained by the passage of a full-sized sound. This is easily done by the patient. In a few lessons, he acquires the art of gently passing a sound upon himself, and he should be seriously cautioned to perform this trifling but important operation once or twice a year. If the sound fails to pass on some such occasion, he must report for examination. In this way, in some cases, the use of instruments may be gradually abandoned. In the majority, it will have to be continued indefinitely, at intervals varying from a week to a year. Thus, the cure becomes radical. The surgeon is responsible for the cure only on condition that the patient carries out this plan, or rather, the patient is responsible for the permanence of his own cure, and this he must be made distinctly to understand.